calcium score. The question was, can chronic venous disease be a marker of systemic vascular disease? Let's see what they found. Guess what? Patients who have chronic venous insufficiency had a significantly higher calcium score, 214 against 65. A severe calcium score of more than 100 was mainly present in patients with chronic venous insufficiency, 35% against 12% of the controls. And in the multivariate analysis, to eliminate all other confounders, chronic venous insufficiency was an independent predictor of coronary calcification. This brings us again back to the concept, and Professor Kikuchi is going to talk about this, of the continuum in the cardiometabolic, meaning patients who have chronic venous disease, this is not an isolated disease. There is likely a cardiovenous syndrome. Chronic venous insufficiency may be a visible marker of systemic vascular dysfunction and a window of opportunity for cardiovascular risk detection. What if our venous clinic became a cardiovascular screening clinic? Think about it. The final abstract, the risk of varicose vein recurrence. Many times we see patients with varicose veins in the clinic and they ask us, doctor, will this come back? Will this recur? Well, this is what this study shows us. It comes from Russia and was presented by Lobastov Kirill. How often do varicose veins recur after modern treatment? So they got 140 studies and they did a meta-analysis. They looked at 40,000 treated limbs with various treatments, foam sclerotherapy, laser ablation, or saphenectomy, and they got a follow-up of 35 years. So what you can see here, that every single year, more and more patients would show up a recurrence. Year number 1, recurrence 8%. Year number 3, 14%. Year number 15, 50% of the patients, 1 out of 2 patients by 15 years will have a recurrence. What this tells us, chronic venous disease is always there. The inflammation is there. So these patients should be followed up for many, many years, and it's highly likely that the disease will come back. So modern interventions are highly effective at eliminating reflux, but they do not cure chronic venous disease. Recurrence reflects the natural progression of the disease over time, and it's not a treatment failure. And I think somewhere here I'm going to stop it, and we are going to continue with the second presentation that comes from Professor Kikuchi. Rodrigo, you can share your screen and take it away.
Thank you so much, Makis. It's a pleasure to be here with you all. And I'm going to actually talk a little bit about how now we think that the heart shapes the vascular decisions, and not only in arteries, but also in vein disease. This is my disclosure for this presentation. I'm right now talk a little bit about a summary in what we saw in the EVF. It was a satellite symposium by Servier, organized by Dr. Mancilla, and also with several very experts on. Oh, sorry. Are you seeing my presentation, Max?
No, Rodrigo. We lost it now for some reason.
Okay. I'll do it again. So with several experts from around the world.
We see the presentation mode. If you can switch screens, yes.
Now we're done. So the first thing is the thing that it is only a coincidence that chronic venous disease and cardiovascular disease, they share the same letters, CVDs. So I'll show in the next minutes that is not only a coincidence, because right now we already know that arterial disease is not only obstruction, it's not only a simple disease, but it is actually a inflammatory polyvascular disease. So at the end, arterial disease now is taking us an inflammatory disease and also venous disease. So venous disease is for us now is also an inflammatory disease. So both of them are inflammatory disease. The first paper that was brought to our attention in this issue was from Prandoni, where patients with DVT had a higher proportion of MI and strokes, and also other arteries disease. And in an observational study with a 10-year follow-up later on with VTE, mortality with MI and stroke was significantly higher in this post-VTE patients as well. So in a more recent study, was made a meta-analysis from several observational studies with patients with VTEs, and both during anticoagulation or after anticoagulation, people with treating on statin, with treatment on statin, was protected for recurrent DVT, recurrent PE, and also from mortality. So people who's under statins, besides doing the correct anticoagulation, was protected from arterial disease. So this was very interesting because this brought it to our attention that some things were mixed. And we know that patients with higher CIP clinical scores had a also more arterial disease, such as high blood pressures and higher stiffness on the arteries. So, you see this progression of venous diseases walking together with the progression of or even the prevalence of arterial and cardiovascular diseases. And this is a classic study from Prochaska. It was a population-based study with more than 12,000 participants. And it clearly shows us that when you increasing the clinical score, the clinical CIP score, you also increases the prevalence of atrial fibrillation, myocardial infarction, peripheral artery diseases, stroke, and also VT. And this give us the adjusted ratio of more than 2 between CVD, chronic venous disease, and cardiovascular disease. So in populational studies, we have this data that show us that they are correlated. And also, we know from these studies that patients with severe chronic venous disease are more intent to have MACE events. So this is also another data that make us think that both diseases are walking together. Venous ulcer is the final stage of clinical presentation of venous disease, and also in population study, venous ulcers are correlated to several other cardiovascular diseases such as atrial fibrillation, heart failure, and also peripheral arterial occlusion. So higher is the clinical stage of venous disease, higher is the prevalence, and also higher is the incidence of MACE events. Also, there's another thing that brought us in one of the BMIs, dyslipidemia, and also calcium score correlated to severe chronic venous diseases. So this is interest for us because chronic venous diseases became an independent risk factor for cardiovascular disease. So In the moment we're treating patients with venous diseases, maybe we are also preventing and treating cardiovascular diseases. In these studies, most of them brought by this Chinese group, researching on genetic factors, they found on Mendelian randomization an association between chronic venous disease and cardiovascular disease. So genetically, they are also linked. In the Prochaska study, we had this final predicted 10-year incidence of cardiovascular diseases in each of the CIP clinical score. So if the patient is between C4 and C6, 1/4 of these patients will develop a incidence of cardiovascular disease in the next 10 years. And we have one very interesting study that showed us it is an observational study. It was not designed for this, but what is interesting, between more than 1,000 patients treated with endovenous laser and another patients who are not treated, they were followed to see the MACE events. What happens is when these patients with venous diseases are treated, they are protected from some of the arterial diseases and also from DVT. So treating a venous diseases maybe protect our patients to develop or developing both DVTs and also cardiovascular disease. So this is on a point of attention, because we already know that both diseases share risk factors such as obesity, age, smoking, diabetes, and also they share inflammatory process of the endothelium, both venous and arterial endothelium. Treating venous diseases is important for us because clinically, in patients, this is a data from a very recent vein step study that correlated CVDs and we studied a specific population of type 2 diabetes, and we know that MPFF can improve symptoms in this particular population. And we also know when clinically treating chronic venous disease with MPFF, we improve global symptoms, pain intensity, but also edema and leg ulcers. So improve all of these issues when treating venous disease with MPFF. Dr. Fabricio Santiago here from Brazil, he managed to publish this in this year, and he showed this in the EVF that MPFF improves the quality of life in patients with CVD in all 4 dimensions: physical, aesthetic, relational, and emotional. So this is pretty interesting. So in the end, when treating patients with CVD, we need to know that we maybe not treating only chronic venous disease, but also preventing cardiovascular disease, because they coexist with cardiometabolic conditions. And of course, we need to manage this disease with several other professionals. So the whole idea now is the holistic patient-centered approach for us when we are treating and managing chronic venous disease. Thank you very much. This is all for now. Marcus.
Thank you so much, Rodrigo. Chronic venous insufficiency equals cardiovascular disease. We're going to talk about it a little later. And our next speaker now, Professor Ferreira from Portugal, from Data to Decisions, the EVF evidence we need. Joanna?
Hello, everyone. It's a great honor for me to be here with you. I'm going to share my screen. So I think you can see it, probably.
Yes. Go full screen.
Yeah. So my name is Joana Ferreira. I'm a vascular surgeon from Portugal, and I'm going to share with you 4 abstracts that were presented at the EVF meeting. And this presentation I'm going to share with you was made from pictures I took at the EVF. I chose these 4 abstracts because they are focused on the venoactive drug MPFF. It is a venoactive drug that we use in Europe for decades. It is recommended by the guidelines of the European Society of Vascular Surgery, but besides that, there is a lot of research focused on the MPFF. And I think that some of this research could be really useful in our clinical practice. So the first presentation I want to share with you is the presentation of Professor Jorge Olhoa, and he analyzed the real-world data about the efficacy of MPFF when compared to diosmin, and he made a postdoc analysis of the vein step study. The vein step study, as said by Professor Kikuchi, is a well-known study from all of us, is a prospective observational study, a multi-center study, and it has a detail that it was designed to collect real-world data on CVD management. And Professor Olhoa made a postdoc analysis comparing the effectiveness of MPFF versus diosmin on patient-reported outcomes. And in the clinical practice of this study, more than 500 of patients were treated with MPFF and more than 1,000 were treated with diosmin. And Professor Olhoa called attention that after 4 weeks of treatment, there was, with both venoactive drugs, a reduction in symptoms related with chronic venous disease. And this reduction was even higher with MPFF. He noted that the improvement of the symptoms occurred at 2 weeks, but were even greater at 4 weeks, and the improvement of symptoms were noted with both drugs, but was more effectiveness with MPFF. And in the same way, there was an improvement in the quality of life, but the results were better with MPFF. So he concluded that over 4 weeks of treatment with both these venoactive drugs, there is an improvement in CVD symptoms and quality of life, but the magnitude of improvement is better with MPFF. The other abstract I want to share with you is an abstract about the efficacy of MPFF in controlling the venous symptoms associated with hormonal changes. And I think this is a quite interesting and original abstract. So the authors decide to assess the efficacy of MPFF treating women with hormone-associated phlebopathy. So they designed a study where they included patients with symptoms of chronic venous disease associated with hormonal changes. They prescribed MPFF with an intermittent prescription, and this is the protocol. So they decided to do 3 courses of MPFF during 3 months, and they were separated with intervals of 3 months. And before and after each course, they analyzed the symptoms of the patients. They picked up 2 groups of patients. So one group of patients they treated with MPFF when they started the contraception, and in the other group of patients, they just started MPFF if the patients develop symptoms. So as we can see, and as expected, in the group A, at the starting of the studies, the patients did not have symptoms, while the group B, they have symptoms. And after the first treatment with MPFF, there was a significant decrease in symptoms as expected. Before the second course of MPFF, the group B keep on with more symptoms than group A, but when both groups were treated with MPFF, there was a decrease in symptoms. And this decrease in symptoms was higher than the starting point of the patient. So this means that the MPFF has a cumulative effect. When they stopped the MPFF treatment, the symptoms returned, but they were not so intense as at the beginning of the trial. And at the end, there was an improvement in symptoms, and the same pattern was seen with distal edema. So the authors conclude that MPFF can reduce the manifestations, the symptoms of hormonal phlebopathy in women. So this is an option that we can think in our clinical practice. The other study I want to share with you is a study of Professor Kakos, and Professor Kakos tried to understand if the benefit of MPFF persisted with long-term therapy. So he made a post-hoc analysis of a systematic review and meta-analysis, which aimed to analyze the effectiveness of MPFF in all stages of chronic venous disease during long-term therapy. So we don't know exactly for how long we should prescribe the venoactive drugs. There is no guidelines with this information, and the information about the efficacy of MPFF after 6 months is limited. So Professor Kakos decided to make a post-hoc analysis to evaluate the clinical benefit of MPFF in patients with chronic venous disease during long-term therapy. So he designed a systematic review and meta-analysis. He included patients with CVD with symptoms in any stage and just studies with more than 6 months of outcomes. It included 7 studies, more than 500 patients, and he noted that with long therapy, there was a reduction in symptoms like heaviness, reduction in pain, reduction in sensation of swelling, reduction in cramps, and he made a lot of conclusions in his presentation, but I want to emphasize this conclusion, that is, the long-term administration of MPFF is associated with symptoms relief and without any serious adverse event reported. The last presentation I want to share with you, I think is quite useful in our clinical practice because all of us tend to prescribe venoactive drugs after intervention, after endovenous ablation or surgery. So we don't know exactly the role of venoactive drugs after endovenous intervention. The real world data is scarce. So the aim of this study was to evaluate the long-term clinical impact of postoperative venoactive drug after endovenous therapy. So in this study, the authors included patients who underwent endovenous therapy, those who were under venoactive drugs and those who were not, and they just look for patients that had more than 5 years of follow-up. So they include 72 procedures, and in these 72 procedures, 39 patients were on venoactive drugs and 32 were not on venoactive drugs. And as expected, after the intervention, all the patients improved the symptoms after the endovenous therapy, but those who were on MPFF had a greater improvement in congestion-related symptoms. And the benefit was the most symptoms where the benefit was evident was on leg swelling and in sensation of heat and burning. So the authors concluded that after endovenous therapy, there was an improvement in the symptoms and that the use of MPFF can help to improve the symptoms in those patients that keep on with symptoms after the intervention. And that's what I have to share with you. Thank you.
Wonderful, Joanna. Thank you so much. MPFF seems there are so many other patient groups that can benefit from it, and we're going to talk about it now in the discussion. I think without any further delay, I think we had 3 wonderful presentations on the insights of the European Venous Forum. We discussed the abstracts, we discussed the new knowledge. Let's see, people who have questions, please put them in the Q&A, and I'm going to kick it off with the questions that I can see. Would you manage patients with family history differently even before symptoms develop? I guess this goes to me now. Let's say patients, we said there are genes that relate to chronic venous disease. So if a patient has his mother or his father with chronic venous disease, if I would start treatment earlier, I would not, but I would counsel this patient that he or she needs to be aware that chronic venous disease will happen down the road and will happen sooner than he or she might expect. So I would reinforce lifestyle changes at this early stage, like retain a normal weight, exercise, leg elevation, maybe compression stockings during long standing, but nothing more than that in the non-symptomatic patient. And I would just also recommend like a frequent follow-up with the physician. I don't know, anyone else would be more aggressive in a patient who just has family history without symptoms?
Well, I will go ahead. Go ahead.
No, please, Rona.
I totally agree with you, Makis, mainly about the lifestyle improvement, controlling the weight and doing during exercise. I think that is really an important point because we are living with an obesity epidemic, and it has a great impact on chronic venous disease and also in cardiovascular disease.
What I think what is interesting because family history, of course, is important, and we know now that we have some genetic proofs that this is all linked. And what I think is that in this kind of patient, we need to be more aggressive on the guidelines of giving them a better quality of life. So I think this is important because right now we are seeing this metabolic changes that our lifestyle is provoking. So I think we need to be more aggressive in this kind of patient with family history. So I think we need to manage these patients with sometimes with more, I would say, be more incisive in changing their lifestyles.
By the way, many patients underestimate their symptoms and they may not kind of consider as a symptom that they have some leg heaviness or they have some leg swelling. So they just neglect their symptoms. They think they're not important. But if we are counseling these patients early, we should make them aware of what are the symptoms that may actually relate to an early stage of chronic venous disease and guide them as needed based on that. So I have another question that goes for you, Rodrigo. Do you think vascular surgeons should routinely assess cardiovascular risk themselves, or should they be referred to cardiologists?
Excellent questions. Excellent question. Then this depends on the country probably and the health system that you are working with. But I would say that yes, we need to understand better, and we need to assess the holistic vision of our patient. So, if you, right now, for example, angiologists, phlebologists, vascular surgeons need to understand better a nutrition, because how are we going to manage our lipedema patients? So, yeah, I do think that we need to understand better clinically and assess ourselves and work together with cardiologists, yes, but I think we need to understand and assess ourselves this cardiovascular risks to our patients, because maybe because chronic venous disease and cardiovascular disease share a lot of risk factors, we are seeing that developing venous disease comes earlier than cardiovascular disease. So this is maybe a sign. So I think this is very important.
By the way, and this goes to all, if you have a patient with advanced chronic venous disease or a patient who has like thrombosis, would you initiate this patient on statins? Because we do
Well,
have
Max,
like indirect evidence that statins prevent a new DVT, and studies may alleviate chronic venous disease.
Yeah, I'll say myself that I put most of my patients under low dose of statins. And we have one histological study, Max, that did was done in venous disease after DVTs. It was a histological study and was about the aggression in the wall of the vein, and we was verified that the patients under statins had a better endothelium and a better health of the wall of the vein. And I take studies myself. So I probably would manage with a low dose of statins. And of course, in seeing the adverse effects of statins, that most of the time that we need to see is the aggression of the muscles and the muscles. But besides that, I would put patients under statins, yes.
I have a question for you, Joanna.
Yeah.
Just to try to answer everyone's question. So how long do you prescribe MPFF? And if the patient is not improving after 4 weeks, somebody's asking, what would you do next? Would you
Well,
continue or would you try to do something differently?
well, in effect, there is a South Korea study about the duration of the MPFF treatment. And according to that study, we should change the duration of treatment according to the stage of chronic venous disease. And in patients with stage 1 to stage 2, we should prescribe at least 2 months. In stage 3, they recommend 3 months. And after it, 6 months. So in my clinical practice, in patients in stage C2, I recommend them at least 2 months. But we know that in our clinical practice, there is a group of patients that does not improve the symptoms. So there is some of them that do not improve. But we know, at least from my clinical practice, that some improve with lifestyle changes. So I will recommend lifestyle changes, exercise, compression therapy, and of course, I try to prolong the treatment.
Okay, another question. Patient-reported outcomes are very important in cardiovascular disease. Should patient-reported outcomes influence treatment decisions as much as duplex ultrasound findings? In simple words, are symptoms enough, irrespective of the ultrasound findings, to initiate treatment, let's say MPFF treatment, for a patient who is complaining, but the ultrasound findings are not as exciting?
Well, Max, yeah,
Go.
Joanna, please. No, Joanna, please go.
It's your time. It's your time. Go ahead. It's your turn.
No,
Okay.
just a minute. We think we know that also that we have CYP-C0S. So this is one thing. And one question that I will put to our audience is: do you think we're treating the disease or the patient? Because in aesthetic, for example, sometimes we are looking for get rid of all telangiectasias, but we need to ask the patient if the patient is satisfied. So better than treating only the ultrasound findings, you need to treat your patient. That's my opinion. So yes, the answer, the simple answer, yes, I would put the patient under pharmacological treatment for that.
Joanna?
Yeah, I will do the same, mainly because of, as Professor Kikuchi said, the patients in stage COS. So they have symptoms, and sometimes they do not evidence in the objective examination of the disease, and they benefit with the therapy. And I completely agree with Professor Kikuchi. We are treating the patient, so the patient should be in the center of our decision. That's all.
Okay, one more question. If you had to pick one shared risk factor between chronic venous insufficiency and cardiovascular disease, which one do you think this is? The most important shared risk factor for you for patients to develop both diseases?
You know, Max, I would say obesity.
Yes, I
Why?
would say.
Yeah, because obesity brings also several other things, just such as peripheral resistance to insulin, more arterial stiffness, and so hypertension. So I'll say obesity is the most important risk factor for both of these diseases.
Joanna?
I
You're
will
muted.
choose obesity as well, because obesity is associated with cardiovascular disease and is associated with chronic venous disease, with progression of chronic venous disease, with severe form of chronic venous disease, and patients with obesity have more intense symptoms. So I think obesity is the key risk factor.
Joanna, I have a question for you, just to help us a little bit understand on when and for how long we should prescribe MPFF in this population that you reported. Let's take the patients who undergo endovenous laser ablation. How long should we prescribe MPFF after that?
Well, the studies we have, the majority of them are after 1 month. So the Bogashev study, I suppose was him, he started MPFF 15 days before the endovenous therapy, and then he keep on during 1 month. So normally I keep on 1 month. In this study I present today, they analyzed after 5 years, but I think that now the most robust evidence, and in other intervention fields, I think is 30 days.
How about the patients, the women who are on contraceptives? When and for how long do we prescribe MPFF based on this new evidence?
Well, that's a good question. I really like that abstract because it's out of the box, it's different. And in my clinical practice, I normally do not pay attention for these patients. So I think I really should pay attention for these patients. And I will prescribe it at least because they have symptoms, so at least probably 2 months, because 1 month I think they will not improve. But I will prescribe the therapy to control the symptoms, as we discussed before.
Anyone else has any question before we sum up? I think these are very, very interesting things we're discussing. Such exciting new evidence came up in the European Venous Forum. I don't see any more questions coming from the audience, so I think I can sum it up. I started with discussing the genes associated to chronic venous disease. This is something we already knew, but what we didn't know is that the progression of chronic venous disease is not inherited. It comes with environmental factors. That's number one. Then chronic venous disease is chronic. 1 in 2 patients will come back within 15 years, so we need to look after these patients lifelong. Then I also presented an abstract that relates directly to Rodrigo's talk. Chronic venous disease does not come on its own. Chronic venous disease, chronic venous insufficiency goes together with cardiovascular disease, goes together with coronary artery disease and increased calcium scores. So there is a cardiometabolic continuum. So our Vene clinic should be a clinic that monitors patients with for possible cardiovascular disease. And then eventually you, Joanna, presented us all the new insights on the role of MPFF in other populations that we have previously not considered. like women who are on oral contraceptives and patients who are undergoing endovenous laser ablation. If they keep going on MPFF, they will have a much better quality of life. But even globally, for patients with chronic venous disease, it seems that MPFF, you showed us a nice comparative study from STEP, MPFF seems to be more efficient compared to other venoactive drugs in terms of quality of life improvement. That was exciting. I want to thank you all for being here with us and sharing your perspective on the insights of the European Venous Forum. Thank you all for attending. And